My name is Kathy Jo Stentz, and I'd like to welcome you to this webinar presentation on aligning medically managed intensive inpatient services to the ASAM criteria. This presentation has both audio and visual. In order to access the slides, you must join this presentation via the specific Skype link that corresponds to this particular webinar on the rollout presentation schedule. You can access the schedule by visiting www.ddap.pa.gov, then selecting the For Professionals tab in the upper right-hand corner of the web page, and then navigating to the ASAM transition page. This presentation will provide a high-level overview of the documents recently released on Level 4 Medically Managed Intensive Inpatient Services. There are two documents or parts for each level of care: the Services by Service Characteristics and a Self-Assessment Checklist. Information from a third document, the Pennsylvania Expectations Addendum, will also be reviewed today. I would encourage you to have the referenced documents available during this presentation, since we will be doing a high-level review of them today. The documents were previously sent out via DDAP's listserv, but they are also available on the DDAP website. Again, if you need to access them from the website now, as was indicated on the slide when you were waiting for the presentation to begin, you can locate them at www.ddap.pa.gov, then by clicking on the For Professionals tab, and then navigating to the ASAM transition page. The service description document is an abridged resource of the information presented in the ASAM Criteria 2013 text. And the self-assessment checklist will assist providers in self-gauging where they are at in the alignment process. These documents are a resource for service alignment. However, they should in no way be a substitute for completion of approved training on the ASAM criteria or having a thorough awareness and use of the ASAM criteria text. There is a lot to cover in this presentation, so we will continue. We will not be taking any questions during this presentation. This is not an open dialogue presentation, but you can submit questions to the resource account, which is a designated email address, ra-dasam@pa.gov. As a side note, while the various documents for each of the levels of care are being disseminated separately by DDAP, all of them will eventually be combined along with the guidance document, and any changes that have been made along the way will be combined in a single final document for ease of reference. Currently, all ASAM resources relative to Pennsylvania are located on the DDAP website. As a review of what we have done so far with the ASAM transition, efforts have been underway over the last several years to transition and align with the ASAM Criteria 2013 in support of Pennsylvania's implementation of its 1115 waiver, for moving to an evidence-based practice assessment and service delivery criteria, and for overall system-wide improvements. Many trainings have occurred during this time frame, with over 8,700 individuals completing the 2-day in-person ASAM criteria skill building training, with additional individuals taking the Change Company's online ASAM trainings approved in January. Guidance documents have been published and released on various occasions. FAQs have been posted, and residential providers have participated in a preliminary level of care designation survey. While agencies have been trained and have been required to use the criteria for level of care assessment, as a whole, we have not directed the official alignment of service delivery to coincide with the criteria. We are now ready to move our system forward with the alignment of service delivery with the ASAM criteria, which takes us to next steps. DDAP has been working collaboratively with the Department of Human Services in order to support treatment providers and payers in preparing to align the delivery of services as described in the ASAM criteria. The alignment focuses on setting, supports, staff, therapies, assessment and treatment planning, and documentation. Providers should begin working towards alignment in the various areas identified in each document and this presentation immediately, but incrementally as needed to appropriately address each item. DDAP has posted a timeline on its webpage to assist with proposed completion times. Please reference this resource for anticipated progress of alignment with the criteria moving forward. Foundational to the alignment process is understanding that the licensing requirements for each level of care are minimum standards for operation. A drug and alcohol license is essential for operating. Alignment with the ASAM criteria is an expectation of quality required as a contracted provider receiving state or federal funds through the SCA or Medicaid that goes beyond the minimum licensing requirement. A provider will not be able to hold a contract to receive public funds without aligning to the ASAM criteria. As stated very early on in the move to using the ASAM criteria, doing such was both an event and a process. There was a date by which all assessments, continued stays, and discharges were to be completed using the ASAM criteria. This has been accomplished, and assessors and clinicians have become familiar with the placement criteria over the past year or so. Now we are ready to proceed with aligning our services to the descriptions as outlined by the criteria. While we will have target dates for completion of certain aspects of this alignment, not everything should occur all at once. In areas where compliance will not be difficult to manage or is actually mostly occurring, the expectation will be that it will occur more readily. In other areas, we will ease our system into particular expectations. In general, most expectations for alignment will occur on July 1st, 2021. For clarity, providers and payers should reference the timeline posted on DDAP's webpage. In all cases, DDAP and DHS will make every effort to support our provider network in aligning with the criteria, as we believe in the importance of working together to improve our system and to deliver an even higher quality of service than we have been accustomed to in the past. Hopefully, if you did not have the documents in hand when we started out the presentation, you do have them now. This slide shows you a miniature version of what we are referencing. Let me point out that documents for every level of care have a similar layout that corresponds with how the information appears in the ASAM text, flowing through setting, support systems, staff, therapies, assessment, and treatment plan review and documentation. While each level of care has the same categories of services and even many overlapping requirements, of course, distinguishing criteria exist for each level of care. As you work to bring your program into alignment, you will want to use the documents applicable to the level of care delivered in your program, in tandem with the ASAM Criteria text, to fill in any gaps. The self-assessment document and the Pennsylvania Expectation Addendum will be especially helpful in aligning your programs to the criteria. I will highlight as many of the requirements and particular changes as we go through this presentation, but not all of them. So be sure to familiarize yourself with these resources that DDAP has provided. Some general aspects of Level 4 programs include the program being staffed by credentialed professionals delivering services in a 24-hour acute care inpatient setting. Level 4 programs encompass a regimen of medically directed evaluation and treatment services managed by a physician who is responsible for diagnosis, treatment, and treatment plan decisions in collaboration with the patient. The physician is typically an addiction specialist physician or someone with significant knowledge and experience with substance use disorder. Because Level 4 program services are the most intensive in the continuum of care, their principal focus is the stabilization of the patient and preparation for his or her transfer to a less intensive setting for continuing care. Because the focus is stabilization and referral, care coordination is exceptionally important in the delivery for Level 4 services. Level 4 services are generally provided in an acute care general hospital or an acute psychiatric hospital that is licensed by the Department of Health and certified by DDAP to provide substance use disorder services. Level 4 programs offer medically directed acute withdrawal management and related treatment designated to alleviate acute emotional, behavioral, and cognitive and or biomedical distress resulting from or co-occurring with a patient's substance use. Life support care and services can usually be delivered at the facility through transfer to another unit within the hospital or to another medical facility if necessary. The key service in this setting is biomedical stabilization. Depending upon which dimension the individual meets criteria for the admission of Level 4, be it dimension 1, 2, or 3, will determine the type of Level 4 setting the individual is most appropriate for. For example, a patient meeting criteria for admission in dimension 3 will likely be admitted to Level 4 program in a psychiatric specialty hospital or a psychiatric specialty unit in a general hospital. In Level 4, necessary support systems include a full range of acute care services, specialty consultation, and intensive care. Access to pharmacotherapy applies to all levels of care. Individuals cannot be denied services based upon their use of FDA-approved medications to treat substance use disorders, and all service plans are to be individually tailored to meet all the needs of the individual. It will be important that medication therapies to treat SUD that have been initiated prior to hospital admission can be appropriately maintained while stabilizing the individual's other health needs. Therefore, access to pharmacotherapy and collaboration with such providers will be an important consideration of care. Best practice indicates that case management should be offered as a standard delivery of care. Case management is defined as a collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates the options and services required to meet the client's health and human service needs. DDAP is working with the SCAs to strengthen case management services as a distinct and separate service from the clinical process so that individuals have the support that they need while allowing the clinician to focus on the therapeutic process. Regarding staffing, Level 4 programs are operated by an interdisciplinary team of appropriately credentialed clinical staff who assess and treat individuals with severe substance use disorders. The Pennsylvania regulation remains applicable as a minimum standard when aligning to the ASAM criteria. Minimum education and training requirements, as noted in the regulation, remain intact for hiring counseling staff, and the overall staff-client ratio remains 1:7, as noted in regulation. The licensing regulation has always called for appropriate and adequate training. However, this will become an even greater focus with alignment to the ASAM criteria. There will be an expectation that staff delivering services to individuals have been adequately trained to provide the services and therapies outlined in the individualized treatment plan. At a minimum, the facility is to be housed with credentialed staff who provide medical management by physicians 24 hours a day, primary nursing care and observation 24 hours a day, and professional counseling services 16 hours a day. Any areas of specialty should be noted on the individualized training plan of the staff, and a record of completed population or service-specific trainings should be maintained. Since evidence-based programs and interventions are foundational to the delivery of quality care, training in the area of EBPs must be indicated for staff delivering such modalities. Moving beyond the minimum requirements of the Pennsylvania regulations, clinical staff will also need to either have professional licensure or those certifications issued by the Pennsylvania Certification Board applicable to the assigned duties of the staff, or be working toward these quality standards after hire. This requirement is more fully outlined in the addendum document, as we will discuss in more detail later in the presentation. A guiding principle of the ASAM criteria is moving away from program-driven to both clinically driven and outcome-driven treatment. Treatment should be individualized based upon the needs identified in the multidimensional assessment. Because the length of stay primarily revolves around stabilization of biomedical needs, the patient's acute signs and symptoms are the primary focus of care at this level. Just as the number of service hours must be determined by individual need, so are the therapeutic interventions. Evidence-based programs and interventions are foundational to the provision of quality care, and while educational efforts will be a part of care, clinical interventions must be therapeutic in nature and not primarily curriculum or psychoeducationally driven. For example, but not limited to, the delivery of therapies such as cognitive behavioral therapy, rational emotive therapy, EMDT, etc., should be delivered within the therapeutic setting and provided by staff members appropriately trained to deliver these therapeutic modalities. As stated, motivational interviewing and stages of change are foundational to applying the ASAM criteria. Therefore, training on this topic will be a required element for alignment and use of the criteria. Since Level 4 services are provided in a hospital setting, physicians and nurses are available to treat an individual holistically and, whenever necessary, engage the individual's healthcare provider as a member of the treatment team. With appropriately signed consent, referrals to and contact with primary care physicians should occur so that continuity of care can occur upon discharge whenever possible. Case management can play an integral role in coordination of care. Because substance use disorder impacts the family as a unit, services and counseling with family members is required whenever possible. This is beyond educational sessions. If individuals are hesitant to involve family members into the sessions, the therapist should begin to explore the reasons why, as this may be a therapeutic exercise for the individual in building the confidence to begin to open up to persons whom they consider family, building bridges and mending severed relationships in the process. Individualized treatment planning is required, as are the use of evidence-based programs and interventions, including case management. While in most cases therapy will be a separate and distinct service from case management, the fact that case management and adjunct services are needed should be noted on the treatment plan, but be delivered by the case manager as a member of the multidisciplinary treatment team. The clinician should monitor progress of these issues on the treatment plan. While the level of care assessment is generally conducted by an entity other than the acute care hospital, there are several issues that require attention regarding the assessment process. First, alignment with the ASAM criteria requires an independent level of care assessment. In instances where this cannot occur, there must be evidence of neutrality. We'll discuss evidence of neutrality in greater detail when we cover items included in the addendum document. Otherwise, assessors determining the need for treatment services that involve significant biomedical care should make this decision based upon current, here and now medical needs rather than historical issues, and obtain supervisory and medical confirmation of the appropriateness of the referral. This can be done through a number of avenues, such as with assigned consent, consulting with the individual's primary care physician, or when making the initial referral to a level 4 program, consulting with the nursing or medical staff of the treating program. In some cases, where the treating facility may be a significant distance from where the individual is being assessed or from where the person resides, medical clearance for travel may be warranted prior to arranging for the admission. Upon admission, there must be a comprehensive nursing assessment and physician approval of admission, along with the completion of a biopsychosocial assessment. Treatment planning should be collaborative with the patient and focused on strengths and needs and prioritized by risk. The patient should always have a copy of their current treatment plan, and it should be actively used as a resource or roadmap during treatment. Treatment plans must be updated regularly. Again, the significance of case management at this level of care cannot be overstated, as once stabilization of biomedical needs has occurred, referral to a lower level of care for continued services and ongoing treatment planning is of paramount importance. Documentation for level 4 programs include individualized notes in each patient's record for every shift. Individualized progress notes should reflect the treatment plan, including the patient's response to medical interventions, as well as the therapeutic interventions or treatment modalities used to address the SUD issues and any amendments made to the plan. Progress notes should be completed as soon as possible after patient contact to fully and accurately capture the content of the therapeutic exchange. Whenever possible, it is helpful to summarize the treatment session in writing while still with the client during individual sessions as a mechanism of review and to present the next step in the plan that are to be addressed. Progress notes should reflect the treatment plan, progress, adherence, and adjustment or updates made to it. Documentation also focuses on care management and coordination of care to ensure a smooth transition to continuing service or another level of care. That takes us through a high-level review of the service characteristics document. Let's review some of the elements of the self-assessment checklist. The provider assessment checklist includes essentials for alignment with the criteria. While this is a self-assessment, it is important to know that as we progress with alignment to the ASAM criteria, service descriptions, there will be a state-level monitoring process in place to affirm the self-assessment completed by providers and to assure that alignment with the criteria has occurred. So, looking at the blue square on page 1 of the self-assessment checklist covering the setting characteristics, a provider would read through each numbered item in the block and place a check mark in the corresponding red circle to indicate that this element already exists at the facility. Those items or red circles that remain unchecked will need to be addressed for the program to be fully aligned with the ASAM criteria. Looking through items 1 through 6 in this list, as well as the lists under the subsequent headings, you will see, in many instances, alignment requires the writing or establishment of policy and procedures for many of the everyday practices that your program likely already has in place. For example, in item number 4, written policy for program admission, transition, and discharge should hopefully already be in place. However, if not, now is the time to establish such policies or to update them to align with the ASAM criteria. Another key component noted within item number 4 of the checklist is consistent evidence of a variable length of stay based upon client need. There should be no designated time or length of stay when using the ASAM criteria. All length of stays should be determined on an individual basis by assessment and need. Therefore, individuals with greater need may require a longer length of stay than someone else. There are 2 characteristics to self-assess under the heading of support systems. As stated earlier, most of these supports will be provided directly by the program staff and some by affiliation and referral if deemed necessary. Policies and procedures should exist when referrals for concurrent services need to occur and how these collaborative services will be delivered. MOUs and letters of agreement should exist where necessary. Additionally, a provider's plan for addressing emergencies with clients must also be addressed in policy and procedure. The items emphasized in the staffing self-assessment checklist include areas such as policies and procedures that outline staff responsibilities for coordination of the treatment plan. For example, medical versus SUD interventions, required credentials and staff qualifications, etc. Staffing scheduling and round-the-clock coverage and availability of medical staff is important at this level of care. As stated earlier, we will discuss the new requirement about credentials for SUD clinicians at a little later in this presentation. Treatment in the level of care, treatment in this level of care involves concurrently delivered services to address biomedical, emotional, or cognitive problems, as well as those aimed at addressing the substance use disorder. As indicated previously, professional counseling services are to be made available for 16 hours per day and should be tailored to and delivered based upon an individual's medical capacity to participate. Such therapeutic services should be available 7 days a week. Again, services in the 4.0 setting are primarily for the purpose of stabilization, at which time an individual would be transferred to a lower level of care. Each 4.0 program will need to demonstrate the availability of a range of evidence-based treatment modalities to treat substance use disorder, to include cognitive and behavioral therapy such as motivational enhancement, cognitive behavioral therapy, rational emotive therapy, etc., as well as pharmacotherapies for the treatment of SUD and mental health conditions. Substance use disorder treatment services may be delivered through individual and/or group counseling, family therapy, educational groups, etc. Health education services are especially important at this level of care. You will notice, as part of this assessment checklist, the need for policies for staff trainings and verification of trainings applicable to services and therapies delivered at the program. In highlighting the assessment treatment plan review checklist, once again, you'll notice there are several items that require the development of policy and procedure to formalize what your agency does in everyday practice to align with the ASAM criteria. Many of these 19 elements are likely already occurring in your facility, so I'll highlight those areas that will most likely need some adaptations in order to align with the ASAM criteria. In many, if not most instances, SCAs or their contracted providers are conducting level of care assessments and referring individuals to providers for treatment services rather than the provider delivering the treatment conducting the level of care assessment. This would ensure an independent assessment process noted in item 14. However, if by chance a level 4 provider must conduct a level of care assessment, there will be a process to ensure evidence of neutrality. We'll discuss this more in a few minutes. In addition to an independent process of assessment, as was mentioned earlier, it is necessary that admission to a 4.0 level of care be affirmed by a physician. Because the need for an acute hospital setting is warranted due to current here and now biomedical or psychiatric conditions, this affirmation of appropriateness to this level of care is best when first made at the point of referral. By having the assessor contact the potential treatment facility and confer with the medical staff, be it a nurse or otherwise, to affirm the referral prior to the individual showing up for treatment will assure that an appropriate referral is being made. This would then be reestablished and confirmed once the individual arrives at the treatment facility. Again, with the documentation checklist, providers will go through this list and check off the items that already exist in their program, as well as determine what areas require attention in order to come into alignment with the ASAM criteria. Moving on to the Pennsylvania Specific Expectations Addendum information, let's discuss staffing credentials first. DDAP embraces the rich heritage of lived experience that has held a long presence in our treatment field and acknowledges the benefit of licensed clinicians as described in the ASAM criteria. By striking a balance of education and training that can be acquired through the certification process, we will continue to have a gateway for those in recovery or those who do not have graduate degrees to gain experience through a mentoring process, while at the same time more fully embrace the credentialing process that already exists in the state through the Pennsylvania Certification Board. Staff hired prior to July 1st, 2021 will not have to meet this requirement as long as they remain with the same employer. However, if an employee hired prior to July 1st, 2021 seeks employment with a new provider, they will need to become certified under the protocol for new hires outlined in the addendum document. New hires after July 1st, 2021 must meet the minimum education and training requirements outlined in the regulation at the time of hire, and then will have 1 year beyond meeting the PCB requirements after hire to obtain certification. Therefore, depending on the type of certification, level of education and experience, this expectation should be met between 1 and 4 years after hire. Because appropriate use of the ASAM criteria is reliant upon a working knowledge of the stages of change and motivational interviewing, all assessors and clinicians should have an immediate foundational awareness of this information. This can be obtained through any number of self-selected online trainings, independent reading, facility in-house guidance and instruction, etc. There are suggested training resources that have been included in other level of care FAQs previously posted to DDAP's website. A record of how this foundational awareness was obtained must be maintained in each employee's training file. However, at some point after July 1st, 2021, staff will need to obtain DDAP-approved training over an incremental time period. Clinical supervisors are expected to have DDAP-approved, and may I say DDAP-provided MI training by July 1st, 2023, and all other clinical staff are to have the training by July 1st, 2026. After 2026, all new clinical staff will be expected to have MI training within 18 months of hire if DDAP-approved training was not previously obtained. Over the last 2 years, DDAP has created and piloted a very effective MI training that has both a classroom and an application component. We have been very busy at expanding the capacity for availability of this training, both in person and online. And currently, the training, it has been mandated for case managers as of July 1, 2020, which is why we are requesting that other clinical staff wait until after July 1st, 2021 to make sure that the case management staff whose expectation has gone into effect prior to the clinical staff expectation, so that they can obtain that training without a capacity hindrance. But again, over the course of the next year, this training should become more readily available, and there should not be a capacity issue for accessing this training. And especially by the 2023 and 2026 dates that are indicated that supervisors and clinical staff must have the MI training. In the meantime, staff are asked to have the immediate foundational awareness obtained by any number of self-directed training application means. With regard to the need for independent assessment, as stated, in most instances, SCAs or their contracted providers are conducting level of care assessments and referring individuals to providers for treatment services rather than the provider delivering the treatment conducting the level of care assessment, especially for hospital-based care. This independent assessment process is necessary across the continuum to avoid bias, as even implicit bias can likely occur. In those instances where a provider of service must conduct a level of care assessment, there will be a process to assure evidence of neutrality when referral occurs. While additional information will be put out by DDAP's County Program Oversight section regarding this, evidence of neutrality will include client choice, data that indicates referrals to providers other than the one conducting the assessments, etc. DDAP and SCAs will begin to include this in the monitoring tool beginning February 2021. When an individual is being referred to any level of care with consent, the level of care assessment should be forwarded to the receiving treatment facility to review with the individual and incorporated into their record as part of the intake process. Best practice warrants that information is reviewed, confirmed, and validated. Review does not mean redo. Instead, the level of care that has been forwarded by the referring agency should be reviewed with the individual, clarified, and even expounded upon if necessary, but not totally redone once the person is admitted for treatment. This is actually alluded to in a licensing alert that was issued some time ago in 2007 and does indicate that the level of care assessment should be utilized and forward on for use by the treating provider. DDAP would like to remind everyone that alignment with the service description continues to be a process in which DDAP will offer as much support as possible. As indicated early on in this presentation, this was a high-level overview highlighting only certain aspects of the alignment process, but certainly not all of them. Providers are highly encouraged to begin the alignment process now by reviewing the service description document, the self-assessment checklist, as well as the Pennsylvania Expectations document as supplemental resources to the ASAM Criteria 2013 text. Providers should begin to identify those areas that require work and create an organizational strategy and plan, including timeframes for completing each of the items on your own to-do list, as indicated by the self-assessment checklist. Use the overall timeline that DDAP has made available on our website to gauge how your plan fits into the expected time frames for alignment. You will see that when the timeline, you will see by referencing the timeline that is posted to our website that most items will be required to be aligned by July 1st, 2021. Therefore, do not wait until the last minute to engage in the process so that you have time to internally accomplish the necessary tasks, to ask questions of DDAP, and if necessary, make adjustments along the way. For those of you who did not already use the chat box to sign in as an attendee of this presentation, please do so by indicating your name, your agency, and your agency's location. For those of you participating by phone, please email your attendance by indicating your name, agency, and location to ra-daasam@pa.gov. Otherwise, please note that you can send any questions you have about today's presentation to the email noted on the slide. For those of you on the phone, the email address again is ra-dasam@pa.gov. DDAP will be hosting 2 question and answer webinars with the same content on different dates. These webinars are scheduled for October 23rd and October 27th. You will join the meetings using the Skype link designated for the specific date you want to attend. The links are found on the ASAM rollout schedule located on DDAP's website. And we will also do a written FAQ, which will be posted on the website somewhere around the same time as the webinars. While questions will be received anytime, in order for them to be included in the webinars or on the FAQ, please submit them to the email address no later than October 19th and include Level 4 presentation on the subject line. Please also note that there will be no certificates of attendance provided for attending this informational webinar. This concludes the presentation on Level 4, Medically Managed Intensive Inpatient Services. Thank you for joining us today, and we do hope that you will join us for the Q&A webinar presentation on either October 23rd or October 27th. Thank you, and have a great day.